associated hydrocephalus and myelomeningocele. Type 3, as we have seen, is a cervical hernia. Type 4 is aplasia of posterior cranial fossa content. Who is the one to be operated? The one affected by clinical symptom. When cranial when syrinx is associated with the Chiari malformation, the compressive surgery is indicated. In neonates, is a surgical emergency. When? As soon as possible, since the pediatric type, Chiari 2, is very fast and very dangerous and deadly condition. Uh, how? Limited bone compression without opening of the dural wire when stand alone tonsillary herniation, otherwise
Sorry, Massimiliano.
associated with the
Excuse me,
syrinx
Massimiliano.
duroplasty
Sorry,
and
Massimiliano. If you could just
wide
delete
compression.
there is a line at the bottom. If you could, there's a line at the bottom which says app zoom press. Please, if you can delete that line, because that is coming in our way. We can't see that.
I hear some voice in the background. Yeah.
It's
And
okay. Carry on. Yeah.
is it a stable condition or reversible condition? Sometimes it's reversible, very rarely. We can see here that we have spontaneous resorption of the Chiari herniation, as well as a spontaneous reduction of syringomyelia. Very rare but possible cases are recorded into the literature. In August 2022, with the Delphi method, we had a very interesting meeting of expert opinion chaired by Professor Salman Sharif. And in that occasion, I faced with the surgical indication for Chiari malformation. And Chiari malformation must be operated when the patient is harboring a headache elicited by Valsalva maneuver with syringomyelia, with foramen magnum cranial nerve dysfunction. And the mechanism are compression and traction. We tried to systematize all the driving forces managing this rare condition in our paper, but the best summary of the surgical alternative was done as a fruit of the consensus conference in spine and also in brain sciences. We tried to further investigate and highlight to the special condition of Chiari 1. And but returning back to compression, compression is primarily due to small posterior cranial fossa, and the therapy is opening posterior cranial fossa and also performing duroplasty. Second mechanism can be hydrocephalus. To operate hydrocephalus is the requisite to cure both ventriculomegaly and syrinx dilatation. When we operate the hydrocephalus, the syrinx disappears, as well as the tonsillary herniation. Craniosynostosis also a pathological condition narrowing the volar skull base, but cranium, but also and mainly the posterior cranial fossa. Abnormality of the upper cervical spine, critical 5, basilar invagination. And here the concept of instrumentation and fusion of C1, C2 complex is the new revolutionary vision and interpretation of my friend Atul Goel. You can see before instrumentation and after instrumentation. But I had a personal experience that someone what seems to contradict this experience. In my personal experience, I have a young guy, 8 years old, with platybasia, basilar invagination, bifidism of C1, tonsillar herniation. After a transoral decompression, you can see here the complete disappearance of the clivus, C1, and the odontoid, with the disappearance of the tonsillar herniation. But surprisingly, this is the first case recorded in the literature. We have a growth of the odontoid and the clivus, as well as regrowth, a recurrence of basilar invagination. So this patient was fixated after odontoidectomy, was one stage combined fixed of C0, C3. Nevertheless, the patient had a recurrence of the tonsillar herniation. And this is a very interesting case to speak about and to think about, in my personal opinion. Then we have arachnoid fibrosis, and this is what happens after opening of the dura when you have a subarachnoid white fibrosis. That one must be removed and corrected. The second mechanism beside the compression is a traction. Traction as is tethered cord. Tethered cord, we have a normal size of posterior cranial fossa. Nevertheless, we have a herniation of the tonsillary systems through the foramen occipitalis. And the Barcelona neurosurgeon Rocco strongly advocated the need to cut the filum terminalis in order to cure 100% of Chiari malformation. But according to the Italian Society of Neurosurgery, we have a first negative position of an national society against this strategy. And also, the literature is quite confusing, because we have this paper with the group of Milorat and Bolognese pushing and proposing the filum terminalis removal as a possible therapy and cure for moderate degree Chiari malformation. Nevertheless, we have a Massimi of our institution, Catholic University of Rome, pediatric neurosurgery section, and he is quite controversial in his conclusion. And finally, a group of Milano de Oliveira stated that there is no scientific support for the filum terminalis resection. And finally, and we so conclude our presentation, we have the idiopathic intracranial hypotension as a traction mechanism for Chiari malformation. The idiopathic intracranial hypotension is a special rare condition where we have to deal with a low CSF volume rather than a decrease of pressure. And the neuroradiological setting of this rare condition is epidural CSF collection along the nerve roots and also retrospinal CSF collection. We have subdural fluid collection, hygromas, hematomas, or enhancement of pachymeninges that can be uniform or diffuse. We have also engorgement of venous structure and pituitary hyperemia, as well as sagging of the brain. In other words, a descent of cerebellar tonsil through the foramen magnum. All these neuroradiological signs are consistent with idiopathic primary idiopathic intracranial hypotension as a driving force, like a sucking force that promotes the tonsillary herniation through the foramen magnum, which is the therapy conservative with caffeine, bed rest, or epidural blood patch, or a fibrin glue patch, or direct occlusion, as occurred in our personal experience. And this consensus conference of 2019, in which I was one of the participants, conclude that symptomatic Chiari malformation must be operated, asymptomatic wait and see. When you have asymptomatic without syringomyelia follow-up, when you have syringomyelia, you have to decompress with duroplasty. When you deal with 1.5 Chiari malformation, first of all, you have to evaluate stability or instability. Just in case of stability, to decompress by anterior approach and stabilize posteriorly. In case of instability, just fix and stabilize with the hardware according to Professor Atul Goyal theory. So I thank you so much for the kind invitation.
Thank you, Massimiliano. I think excellent talk as always. I'm sorry there was a lot of disturbance at the background, and I know you are in a meeting, so it wasn't possible to have a clear room. But thank you for your talk.
Thank you. I'm so sorry, but I'm ENS Congress. I'm the slide center. I ask the courtesy to present my talk in the slide center. So many people is running around me, and I'm so sorry for that. But it was the only way to participate and to accept this kind and very, very grateful invitation. Thank you so much.
Thank you. Thank you very much. I think we're going to move on. George Leclerc, please carry on. We'd be grateful.
Mehmet, can you see my presentation? Do you see my presentation?
Not yet.
Not yet.
How do I do that? Sorry.
You can share. You can click the share button.
At the bottom, the green button.
Green button at the below.
Yeah.
Yes. Now we see.
Okay. Sorry about that.
Fine.
Let's see.
Make the
now. Can you see my presentation?
But there is something wrong that actually we see. Yeah.
You should see the original classification of Chiari 1, 2, 3, and 4.
Yeah, we're seeing that, but we're seeing you as well as half of it. So if it's possible, maybe if you could just adjust that for us.
How do I do that?
If you exit and then, yeah, here you should have a slideshow somewhere. Sorry, it's in German. Otherwise, I would have told you. Any German friends can help?
Well, I presume I just continue. Otherwise, we'd use too much time.
If you could increase the size of your thing on the right side. So can you see two pictures there in front of you, yourself and this?
No.
No, it's okay. Then just carry on. I think we'll manage.
Okay. Is this better now?
We'll manage. It's okay.
Okay. So we already heard about the classification by Hans Chiari, 1, 2, 3, and 4. I can quickly go through it. Chiari 4 is a hypoplasia of the cerebellum with a communicating fourth ventricle. The Dandy-Walker malformation is related to it, likewise with a cerebellar hypoplasia, but an obstructed, dilated fourth ventricle representing the Dandy-Walker cyst. Here you see a Chiari 4 with a normal-sized posterior fossa and no enlargement of the posterior fossa, and here, by comparison, the large Dandy-Walker cyst with the Dandy-Walker malformation, just to define these two signs and types. And then Chiari 2, already heard, is related to myelomeningocele and spinal low pressure syndrome in utero, which causes herniation of cerebellum and brainstem into the spinal canal, enlarging the foramen magnum, associated with a small posterior fossa and hydrocephalus as soon as the child is born. And it's a clear-cut CNS malformation. Chiari 3 has an additional occipital encephalocele on top of it. We've already seen that. Chiari 2 here, a typical example, with the enlarged foramen magnum, the beaking of the mesencephalum, the wide interthalamic adhesion, and here, by comparison, the Chiari 3 with the occipital encephalocele associated together with the Chiari 2. And I like to emphasize on this picture on the left, the large sinus you can see inserting right at the foramen magnum at the posterior rim, which is why you shouldn't decompress the Chiari 2 at this area, because you will run into trouble with this large vein. Chiari 1, by comparison, is a completely different disorder, characterized in the congenital form by a small posterior fossa. It is not a CNS malformation, but the cerebellum simply has to adapt to the altered posterior fossa size. And the second type of Chiari 1 is the acquired one. We've already heard about this, related to craniosynostosis, birth trauma, posterior fossa tumor, hydrocephalus, spinal CSF loss, or vascular malformations. If you want to compare Chiari 1 and Chiari 2, there are some important aspects to notice. First of all, the site of compression in Chiari 1 is in the foramen magnum, where it is in the cervical canal in Chiari 2. Hydrocephalus is only affecting a minority in Chiari 1, but the overwhelming majority in Chiari 2. And a tethered cord is rare in Chiari 1, but almost obligatory in Chiari 2, related to the myelomeningocele. So Chiari 1, commonest craniocervical malformation, and it can be associated with other skull-based malformations, such as a shortened clivus, occipital hypoplasia, or malformations of craniocervical joints. The pathophysiology has already been mentioned. Brainstem compression is one. CSF flow obstruction leading to syringomyelia is another mechanism. Arachnoid scarring is another mechanism. Hydrocephalus, and there's also some patients who will have craniocervical instabilities. So I'd like to show you this slide, which is not too familiar to most neurosurgeons, and that's concerning the different growth periods of the human brain after birth. If you look at the time of birth, then you will find that the cerebellum, in relation to its adult size, is the smallest part of the human brain at this time. And the growth period goes well up to 18 months of age. So by the age of 2 or 3 years, the cerebellum has reached its adult size. By comparison, other parts of the human brain are much smaller, much larger at the time of birth, and will not increase so much in volume as the cerebellum. And this may be the cause why symptoms of Chiari 1 and Chiari 2 are so dramatic in the age group under 2 years of age, where it can be a life-threatening complication, as already mentioned by my previous talker. So once the patient has reached the age of 3 and the cerebellum has outgrown, the symptoms of a Chiari malformation are not as dramatic and are more in a chronic, slowly progressive fashion. Interesting to note that in children, occipital headaches affect only about half of the patients, whereas it's very common in adults. And scoliosis is probably one of the leading symptoms in Chiari 1 in the young age group. So what you have to check when you see a patient, look at the amount of tonsillar descent, and remember that depending on the growth of the brain, the growth of the skull, a tonsillar descent of 6 millimeters is normal in a child up to the age of 10, whereas the 5 millimeter applies to patients between 11 and 30. And older the patient is getting, the descent is retreating because of shrinkage of the human brain with ongoing age physiologically. So syringomyelia in Chiari 1, up to 50% in young children, in adults, and it's more close to 75%. So we have to also look at other skull base anatomy and the anatomy of the craniocervical joints in patients with Chiari 1. We have to look at the COC1, C1-C2 joint. We have to check the clivus canal angle. We have to look for occipitalization of C1, and we have to look for evidence of basilar invagination. Here you can see the normal joint anatomy of COC1 and C1-C2, and the criteria which are used to diagnose instabilities of COC1 are the Harris measurement, as you can see here. Another is the Schmidt-Fischer angle, looking at the angle of the both condylar joints. If that is increasing beyond 130 degrees, it indicates condylar or C1 hypoplasia. But most interesting is a recent paper from China showing the different types of condylar dysplasia that can give rise to COC1 instability. And what you can see here in this patient is a Chiari 1 with a basilar invagination type 2. You see the medullary compression from the odontoid, but if you look at the condylar joints on both sides, you see that they are luxated. So this is a COC1 luxation in a patient with a type 2 basilar invagination. So check for the anatomy of craniocervical joints in patients with Chiari 1. Similar for C1, C2. We know the normal definition of C1, C2 instability with pathological distance between atlas and odontoid increasing 3 millimeters. We consider this unstable. But we also have to look at the C1, C2 facet configurations. And if you see, as in this case here, anterior slippage of C1 over C2, that's a clear indication of instability. The clivus canal angle is also interesting to look at because it will give you an indication whether there is craniocervical kyphosis, and this can be a sign of craniocervical instability. Here you have a patient with occipitalization of C1. You can see it on the coronal and on the parasagittal planes quite clearly with a normal appearing C1, C2 joint below. Basilar invagination is defined by a line between the posterior rim of foramen magnum and the hard palate. If the odontoid peg crosses this Chamberlain's line by more than 5 millimeters, this is considered a basilar invagination, and there are a number of bony malformations associated with it. They all are associated with reduced posterior fossa volume, so Chiari 1 is a very common association with basilar invagination. There are two types according to goal, depending on the presence or absence of a C1, C2 dislocation. And here you can see the two types, one with the atlantoaxial dislocation where the odontoid is entering the posterior fossa, and type 2 where the odontoid peg is staying below the foramen magnum line, but still crossing Chamberlain's line as nicely seen here. So the neuroradiology has to check for progressive tonsillar descent. So if you have a chance to look at different MRI scans taken over a certain amount of time, and you see a progressive tonsillar descent in a patient older than 3 years of age, you have to remember that the cerebellum is no longer growing. So if the tonsillar descent is progressing, then you have either spinal CSF loss or an increased ICP from hydrocephalus or a posterior fossa tumor, or you have progressive craniocervical kyphosis or atlantoaxial dislocation. So this has to be looked at if you see a progressive tonsillar descent beyond the age of cerebellar growth. And here's an example of an adult patient with basilar invagination type 2 and increasing cerebellar descent over a period of 6 years related to progressive craniocervical kyphosis. And here, a similar picture with a with an atlantoaxial dislocation. So differences between Chiari 1 and Chiari 2, I have to add basilar invagination affects about 10 to 20% in Chiari 1 and is rarer in Chiari 2. So in summary, Chiari 1 is a bony malformation, while Chiari 2 to 4 represent CNS malformations. Chiari 1 is related to an undersized posterior fossa. Chiari 2 is related to an intrauterine CSF loss via the myelomeningocele. Both Chiari 1 and 2 may be associated with malformations of the skull base and craniocervical joints. Progressive dorsal descent beyond age 3 indicates a disease process related to raised ICP, spinal CSF loss, or progressive craniocervical kyphosis. Thank you.
Thank you, George. That was excellent, brilliant talk. If you have any comments, then we can have the discussion at the end otherwise.
Yeah.
Okay, we move on, and hopefully, George, would you like to introduce the next two speakers, please?
The next speaker, according to program, is Juan José Mesadri, who will talk about indications for surgical interventions in Chiari malformations.
All right, thank you. I will share my.
Can you please unshare yourself?
I will try.
George, please.
Unshare.
Okay.
Just 1 second. George is unsharing, and then we move forward.
Oh, sorry. How do I get back here?
Yeah, right.
Oh.
Okay, that's okay. That's fine, and we can see your slides, Jan Jose.
Okay.
You can see it? You can see it?
Yes.
Yes.
Okay. Well, thank you for the invitation. In this presentation, I will deal mainly with or only with Chiari 1 malformation. First, I am going to divide my presentation into 3 parts. First, I will talk about what we do in our program. Then I will show what the international guidelines teach us. And finally, I will outline a flow chart on when to consider surgery. First, let me give you the specific thresholds or red flags used in our program that alert us that surgery may be necessary. First, posterior fossa crowding in MRI. Also, tonsillar descent below the foramen magnum. But remember that the degree of descent alone is not an indication for surgery. Also, the presence of syringomyelia, and finally, evidence of increased CSF velocity at the foramen magnum superior to 5 centimeters per second. In spite of the red flags, not every patient requires surgery. Our decision for surgical intervention is always based on a combination of 3 items. First, progressive or severe symptoms like the classical occipital or suboccipital headaches and neurological dysfunction. Second, the presence of syringomyelia, especially if progressive or symptomatic. And finally, the evidence of obstructed CSF flow on phase contrast MRI. We think that the increase in CSF velocities is more significant than the absence of flow in the posterior fossa. We consider that the following are not indications for surgery, classically symptomatic patients and also patients with mild stable headaches. Unfortunately, we do not have clear levels of good evidence to guide our conduct. The strong evidence from meta-analysis and randomized controlled trials are lacking. Therefore, it is wise to analyze the main guidelines or official consensus of the international societies. Here, I will mention 3 of them: the European Consensus, the Congress of Neurological Surgeons, and the World Federation Spine Committee. Here are the papers where you can read the more recent guidelines or recommendations of these three consensus. As a summary, these guidelines point out that always symptoms drive surgical decision-making. The presence of syringomyelia is a strong indication overall in pediatric patients that the study of CSF flow help us in borderline cases. We must perform fusion in cases of C2, C1 dislocation, and of course, in asymptomatic patients, you must leave them and only make a thorough follow-up. Here is a brief or concise flowchart of surgical indications based on our experience and the consensus guidelines. We can see that in symptomatic patients, we always consider surgery overall in typical cases, also in patients with basilar invagination with or without C1, C2 dislocation, and in atypical cases with mild symptoms, it is important to measure the abnormal CSF flow. In cases that are not symptomatic, in asymptomatic patients, with syringes, if we consider surgery, especially if it's a pediatric patient, to help to prevent scoliosis. In asymptomatic patients without syringes and a normal CSF flow, we only observe. Finally, we can say that the decision to operate is primarily driven by the presence and severity of symptoms and the presence and progression of syringomyelia. In asymptomatic patients without a syringe are managed conservatively with observation. Thank you.
Thank you very much. Should we continue with the next presentation, or?
Yeah, please, and then we can have discussion at the end. Sure.
I think that's most sensible. So our next presenter is Atul Goel, who will talk about the necessity for fusion in Chiari malformations.
Okay. I will try to share his talk because he sent a video recording.
Okay.
Although he's connected now, but he's in a journey, I think. I'm now sharing. Do you hear the voice?
No,
No?
not yet.
Oh. Is it? Sorry. Maybe.
Shall we get Pravin to talk, give his talk first, and then in the meantime we can adjust this?
Yeah. Or I can unshare.
Sure.
Share computer sound. Sorry, just a second. Imat, where is that share computer sound?
Okay, we can see it now, and you can play it.
Do you hear the voice?
Not yet. We can see the video, but we can't hear the voice yet.
Probably Apita is with us. He can share. He can share it.
Okay.
So then I'm unsharing. Stop sharing. Maybe the other speakers may make his talk, and then Abita will share.
So we continue with Dr. Salunke, and then we come back to Atul's talk, okay?
Definitely, yeah.
Yeah. So I've introduced Dr. Salunke, also from India, with a talk on surgery with decompression for Chiari malformations.
Yeah, thank you very much for the invitation. And I think I'll straight away share my slides. So is that visible now?
Yes.
Right. Yeah, so I'm going to talk about, it was actually, it was, my talk was following Professor Goel's talk. And this was actually controversial as compared to his philosophy. So it would have been better if he would have spoken first, but nevertheless, this is going to convey the whole thing. Right, so I'm going to talk more about the decompression and why is it necessary for patients with Chiari malformation. I have a disclosure. Professor Goel has a strong influence on my work, and I've been following his work and have learned a lot from him. And, this has been my journey over the last 20 years, and I've been really lucky to have him very close. But I have a different take when it comes to Chiari malformation. He says Chiari malformation is secondary to the instability, and decompression is not the treatment, fixation is the treatment, irrespective of whether you see apparent dislocation or not. So that is where I would like to differ, and I would like to share my own experience on this subject. C1, C2 fixation, I feel, may be an overkill in all cases. And decompression is the key. If you have listened to all the previous speakers, finally it all comes to decompression, irrespective of what is the cause of Chiari, primary or secondary. When we look at Chiari malformations, these may be present in utero as well. I mean, you can diagnose them in utero, whereas you never get to see atlantoaxial dislocation in utero. Of course, you may have patients with deformed joints, children with deformed joints, born with deformed joints, but they're never born with dislocated joints. They're born with Chiari malformations, but not with dislocated joints. So Chiari malformation cannot be a result of instability. That's the first point I would like to make. It cannot be a result of instability. It's like saying if you have listhesis, dysplastic listhesis associated with spinal dysraphism, meningocele, and the treatment of that would be actually fixing the lumbosacral spine rather than taking care of the meningocele. It doesn't sound really rational. So Chiari is unlikely to be a result of instability, and majority of the patients with apparent atlantoaxial dislocation do not have Chiari malformation. So this is something which is very typical because, Chiari cannot be a protective mechanism. It cannot be secondary to atlantoaxial dislocation because majority of them do not have Chiari malformation. Almost 70% of them do not have Chiari malformation in those patients who have apparent atlantoaxial dislocation or the so-called basilar invagination. And the other way around is also true. Majority of the patients with Chiari malformations do not have apparent atlantoaxial instability. So is the nature unfair for those without the protective phenomena? That is something which we need to ponder upon. Decompression, as the previous speakers have all spoken about, foramen magnum decompression, posterior fossa decompression, and increasing the volume. 70% of them have good outcome. This has been my experience, and I'm sure the previous speakers would also have a similar kind of experience. 70% of them have a reasonably good outcome. And this is for Chiari without the so-called atlantoaxial dislocation or apparent atlantoaxial dislocation. Even some patients with Chiari malformation may have some ventral compression, the so-called clival canal line, and there's some ventral compression in a couple of patients. And we had published this, so you can see that And even posterior fossa, simple posterior fossa decompression in these patients works in majority of them. This is an example where we can see just pure posterior fossa decompression, and you can see the syrinx disappearing, the Chiari reversing. So all that happens, ascent of the tonsils. So FMD still works, that's foramen magnum decompression still works in majority of the patients. When we talk about decompression, it's also ventral decompression. Again, one of the previous speakers had spoken about transoral odontoidectomy and reversal, ascent of the Chiari and ascent
İlk
of the
konuşmacıda
yeah.
sorry.
Yeah, so odontoidectomy, and however, once you have done that, it would require fixation. So this is an example. You can see that, and after transoral decompression, you can see a reversal of the Chiari, ascent of the tonsils, and disappearance of the syrinx. So of course, this is what we do. We follow what Professor Goel had actually given us in India. And this is an example of, look at the C1, C2 is actually, there is a relationship alteration. So you can see that very clearly. There's an altered relation between C1 and C2. And the so-called basilar invagination is actually a telescoping of C2 within C1. It's the vertical invagination or dislocation of C2 within the C1. And of course, if you fix that, just the posterior fossa, there's tonsillar herniation, but apart from that, you can also see there is some ventral compression. You just fix the C1, C2 in the reduced position, and there is ventral decompression. So finally, it is decompression. Even that fixation is actually gaining posterior fossa volume ventrally in an indirect fashion. So this is what we had published previously. This is Chiari with atlantoaxial dislocation, or the so-called basilar invagination. You can see there is the dens which is invaginating within the posterior fossa, reducing its volume, creating a further loss of volume of the posterior fossa. And it is not only the volume of the dens, look at the tenting of the dura. So it's a three-dimensional thing, it's a tenting. So the actual volume of the dens which has invaginated and the actual tenting of the dura, which causes a loss of the volume, is far more than the actual volume of the dens. And the moment we de-telescope this kind of invagination, it is going to gain a considerable amount of volume in the posterior fossa. So that is the whole concept, and this was again published. So it is foramen magnum decompression without any bony removal. So that was the concept. It's a ventral decompression, indirect ventral decompression, nothing to do with instability. This when applied to patients where there is no apparent instability. Here's what you see. This is all, there is some platybasia, there is kinking, there is ventral kinking, there is clival canal angulation is changing. The moment you distract the C1, C2 and fix it, there is increase in the posterior fossa volume. There is de-telescoping of the C2. And this is irrespective of the instability. You just fix them together, the angle changes, and there is a considerable increase in the ventral volume of the posterior fossa. And that is what brings about improvement in the patients. So this is what, again, we have published. These are a couple of examples where we followed what Professor Goel had given us, but on a different, with a different perspective or a different rationale. So that is the concept, that you just reduce, you fix the C1, C2 with some distraction, and it brings about increase in the posterior fossa volume ventrally, decompresses the canal ventrally, and that is what brings about a significant improvement in majority of the patients. So this is what we have seen. Look at those examples. Another example, significant syringomyelia, C1, C2 fixation, and believe me, none of them required any posterior fossa decompression at that time. So this is what is the concept. You can see the entire C1, C2 gets de-telescoped after C1, C2 fixation. There is change in the clival canal angulation, and there is ventral decompression, which is brought about by this technique, reduction in the syringomyelia, ascent of the tonsils. And yet another example where you can see the same thing, there is a change in the clival canal angulation after the C1, C2 is fixed. And this is what brings about the change in the decrease in the syringomyelia and reduction of the herniation. So that the concept is of ventral foramen magnum decompression without bony removal. That is what I would like to highlight. It's all about decompression. And then we did a lot of these cases without any apparent, the so-called basilar invagination, no apparent atlantoaxial dislocation. And what we saw that the improvement was seen only in 70%. It was not in all the patients, and it was almost as similar to those with posterior foramen magnum decompression. So finally, we realized that this is probably not the cause. And there are a lot of difficulties which are encountered while performing a C1, C2 facetal fusion, especially in patients with Chiari malformation. That's because there's a significant venous congestion, incurved occiput, making the exposure of the assimilated C1 facet quite difficult, anomalous vertebral artery, which is seen almost in 30% of the cases. And of course, we need to cut the C2 nerve root quite often to expose the facets properly. This is yet another example, which is a true basilar invagination. Now, what the type A and type B, which was previously mentioned by Professor Goel. So this is extremely difficult. Try to fix the C1 and C2 in these kind of cases from the posterior aspect, and it is going to be difficult. So we did that. It's not that we didn't do it, and you can see that there is some D-scale telescoping, but the final outcome wasn't all that great. So we have problems of fixation, loss of neck movement, which is, it's quite unacceptable to a lot of patients. And finally, there's improvement only in about 70% of the patient. 30% keep on complaining that there is no improvement, and some of them even worsen with time. So now I'm going to talk about the failure of C1, C2 fixation in these patients, and we can see that this is an example. There has been reduction, increase in actually the syringomyelia, and there's no change. This is another example. You can see that the syringomyelia has actually increased. Though, yet another example, you can look at that. This is post-fixation, and the syringomyelia has actually worsened with time, and there was no apparent atlantoaxial dislocation in the preoperative period in any of these patients. So Chiari cannot be a result of the instability. Fixation alone is not going to help. Decompression in whatever fashion, posterior, ventral, whatever, direct, indirect, it's going to help. So it's easier to begin with a posterior fossa decompression. If it fails, then probably we can go ahead with a C1, C2 fixation. And ventral decompression only in cases where there's kinking or signs of brain stem decompression. So this is what we published. The perception about the Chiari malformation is changing in the last 2 decades, but what has not changed is the reality. And it is questionable how effective is a C1, C2 fixation in patients without any apparent instability. Again, we had a couple of more publications out of this. And so instability, somebody spoke about facets. And if you look at those facets, I'll give you an example. Now, this looks quite dislocated, unstable. So right facet has moved, the C1 has moved in front of the C2, and the left one has moved posterior to the C2. But this was a patient who was lying with his head turned in the gantry. This was a normal patient. There was absolutely no instability. So just looking at one parasagittal cut and saying that this is unstable, looking at the facets where there is no instability and saying that this is unstable, and fixing C1, C2 is something which is, it is difficult to fathom and understand. So this is the normal anatomical variation or normal anatomical picture which is picked up in different positions or variation of the position of the head inside the gantry, and one needs to carefully look at it before just labeling the patient as unstable at the CV junction. Again, when you have hydrocephalus with Chiari, decompress the ventricles, Chiari reverses. We have already heard it from the previous speakers. So it's a ventricular decompression. When you have syndromic craniostenosis with Chiari, again, posterior wall decompression, recently published by Gaurish and Sinali, and you can see that there is ascent of the tonsils, reduction of the syringomyelia. So it's finally about decompression. So it's all about decompression in some way or the other. If you decompress the posterior, the fossa, increase the posterior fossa volume in one way or the other, we have a lot of improvement in the Chiari and the syringomyelia. So decompression is the key. We decompress whatever ventricles, if there's hydrocephalus, posterior fossa. If we don't see any ventral kinking, we can do a ventral decompression by C1, C2 distraction, fixation, or odontoidectomy, and posterior cranial wall distraction in cases of craniostenosis. Having said that, it's very important that if there is apparent instability, there is no doubt that you have to fix the C1, C2. We have already published that in case of Chiari malformation associated with the instability needs to be treated. The posterior fossa volume increases, and there is no need for any further foramen magnum decompression. So this is what we follow. If you have a ventral compression or kinking, irrespective of the apparent instability, then we would like to distract the C1, C2 and fix it. Without that, we would go ahead with the foramen magnum decompression in patients with symptomatic symptomatic Chiari malformation or syringomyelia. Finally, irrespective of all the treatment modalities which have been, we have worked out that if you look at the quality of life of patients, patients with Chiari malformation do not really are not very happy after surgery, and it seems that we are barking up the wrong tree. Probably the pathophysiology of Chiari is less understood, but as of now, decompression in some form appears to be the key, and a better understanding in future would give rise to newer modalities and better modalities. Thank you for your patient listening. Thank you.
Thank you very much. I'm grateful for your comment on facet dislocations. Obviously, you have to see it on both sides to be sure that an anterior facet dislocation is indicating instability. Otherwise, you're quite right. It may simply be related to a slightly rotated head. So now we make a second try on Atul Goel's video.
Yeah, this time Apita will share his talk. She's a co-worker of Dr. Goel. Yes, Apita.
Can you see?
Yes.
And you can hear?
Not yet.
My dear friends,
Yes, now we hear.
Okay.
A complete revolution in the treatment of Chiari not malformation, formation. And I'm introducing, or maybe you have already been introduced by me earlier.
Apita, we cannot hear now.
We lost the audio, yeah.
Okay, now you can.
Bone anomaly in the craniovertebral
Yes.
junction. Maybe it is associated with basilar invagination. Sometimes it is associated with syringomyelia and syringobulbia. Basilar invagination, syringomyelia, and Chiari malformation are common clinical triads. And these kind of complex anomalies with Chiari, with syrinx are also frequent. Chiari with basilar invagination, Chiari with no bone malformation, no facetal malalignment is a more frequent understanding. And whatever slides I have shown you, if you carefully look at those slides, the posterior fossa is not tight. You see the subarachnoid spaces see the fourth ventricle. It is not a tight posterior cranial fossa. Syringomyelia with manifest. You see, there is manifest atlantodental interval disturbance. This is unstable spine. We all know it. And Chiari and syrinx. So this is relatively less common. With no bone abnormality and Chiari and syrinx is a more common clinical entity. This is another case where there is no bone abnormality, no facetal malalignment. There is syringomyelia and little bit of Chiari. For all these anomalies, whether it is basilar invagination associated, whether it is syringomyelia associated, whether it is Klippel file associated, Chiari, the important and most important issue is the whole world currently is treating these anomalies with foramen magnum decompression. Some people remove tonsils, some people open the fourth ventricle and obex and portal tube and all those kinds of. So decompression is essentially the treatment. About 15 years ago, we introduced this article that atlantoaxial instability is the nodal point of pathogenesis of Chiari malformation, and atlantoaxial fixation or stabilization is the treatment. And many of you who are in the business of Chiari have seen this article, and also you have seen the various letters to editor from a number of authors to Journal of Neurosurgery when this article was published. And these articles and discussion form an important milestone in the understanding of Chiari and in the treatment of Chiari malformation. Further, about 5 years ago, I introduced another article of mine where we discussed 388 cases of Chiari malformation or formation, where all these patients were treated by only atlantoaxial fixation. And I can tell you, my dear friends, either you read this article or you listen from me, that a magic treatment is available now for this entity. This is 5-year-old paper. Now my experience is beyond 600 cases. There is no doubt or no question in my mind. And you please don't keep any doubt in your mind that atlantoaxial stabilization is the treatment. Compression, we are all talking always about compression, and we are all doing decompression. In craniovertebral junction and in spine, my feeling is compression is always secondary to unstable spine. It is naturally protective, and it is reversible after stabilization. Basilar invagination, I just want to briefly discuss the history of my understanding about this subject. In 1998, we talked about basilar invagination of two types. Type 1, when odontoid goes up, and type 2, when tonsils come down, or Chiari malformation. This only treatment for this entity was decompression in 1998. So we did transoral decompression for this and foramen magnum decompression for this. The role of stabilization was unclear. In this article, for the first time in the literature, we introduced the concept of tight posterior fossa, that there is a bony tightness in the posterior cranial fossa, and we recommended that only bone resection is good enough for the treatment. There's no need to open the dura. So I was personally doing quite a number of decompression cases. In 2004, the same entity we divided into two groups. Here we said that this is an unstable situation, and this patient needs realignment and stabilization. In 2004, my concept was still that foramen magnum decompression is the treatment for group B, basilar invagination. So for group A, over the years, we have done several hundred cases where we have not done any decompression, realignment and stabilization. Realignment and stabilization is now the accepted norm throughout the world, and decompression still some people do, but decompression is not currently the accepted choice. So we have done several cases where realignment has been done. So I have no hesitation to say that we were responsible for completely demolishing transoral decompression surgery from the books of neurosurgery, and it is certainly, in my view, an historical operation. We subsequently introduced the concept of vertical facetal instability due to muscle weakness. It is more relevant to subaxial spine, for degenerative spine, for lumbar canal stenosis, for cervical spondylotic myelopathy and things like that. But it is also relevant for craniovertebral junction. In 1999, we introduced a beautiful concept where we related basilar invagination to instability, C1 over C2 listhesis, like lumbosacral listhesis. And in 1999, these images are from 1999. Can you believe, 26 years ago, where this basilar invagination was related to listhesis, and realignment and stabilization was done without any kind of decompression. This is another case during the same time, Chiari, basilar invagination, C2-3 fusion. So listhesis or unstable spine is the issue, and we did stabilization. And similar other cases and several other cases where we talked about facetal listhesis as the issue. More recently, about 10 years or 15 years ago, we introduced believe me, a complete revolution in craniovertebral junction region where we said and we talked about central or axial atlantoaxial instability being the cause of several so-called pathological entities like Chiari malformation, basilar invagination, and things like that. So just to briefly talk to you about what I mean by central instability, you have seen that C1 over C2 listed is the cause of basilar invagination, instability is the issue, and stabilization is the treatment. Now you look at this slide, type 2, the basilar invagination, there is no atlantodental interval disturbance, but you look at the facets, there is retrolisthesis, this is completely unstable and you need stabilization. So there is no atlantodental interval disturbance. Similarly, there is no atlantodental interval disturbance in this, but there is Chiari, there is syringomalia, there is assimilation of atlas and platypesia and things like that. All these things indicate unstable spine, C1, C2, stabilization is the treatment. So this is the concept. So when there is no atlantodental interval disturbance, I call it chronic instability. I call it central instability. So type 2 and type 3 are central or axial instability. So carefully look at this slide. Central or chronic instability is the cause of several. These are only very few mentioned here, but there are several more. Like Chiari malformation is due to instability. Syringomalia is due to instability. Basilar invagination is due to instability. C23 is a chronic, natural, protective, adaptive response to chronic instability. When Chiari is present alone, or Chiari is present with syrinx, or Chiari is present with syrinx and basilar invagination, or syringomalia is present alone, or basilar invagination is present alone, or bifid is present alone, or odontoideum, all these indicate atlantoaxial instability, and all these indicate the need for atlantoaxial stabilization. So I wish that you please read this article. If you are really interested in revolution, or if you are interested in lectures and all, then just go on listening what I'm saying. This article will give you latest information about what I talk and what I mean about central or axial atlantoaxial instability. So look at the facet. They may give some information. If the facets are normal, then also there can be atlantoaxial instability. So there is a retrolisthesis, there is Chiari malformation. Decompression is a completely negative operation in all these cases. And you do learn to do C1, C2, you create a magic with the radiology and with the patient. So there is basilar invagination. The whole world will do foramen magnum for Chiari malformation. This is a negative form of treatment in the presence of retrolisthesis, in the presence of unstable spine. You have to do fixation and you have to only see one thing, and that seeing is a magic with the patient, with the radiology. When there are complex anomalies in this with Chiari and syrinx, you have to do C1, C2 stabilization. When there is no facetal malalignment, no atlantodental interval disturbance, presence of Chiari, presence of syrinx, presence of basilar invagination are all children of one father, and that father is atlantoaxial instability. You do C1, learn to do C1, C2 fixation. Difficult. Many people question me, but how can you justify fixation in this when there is no radiological evidence? So we have started doing dynamic imaging, rotation of the head and analyzing the facets. If you carefully see this, there is syringomalia, there is no Chiari, there is no facetal malalignment, but you see the facetal malalignment on head rotation. I'm not sure if you can see clearly. This is C1 facet, this is C2 facet. It is almost rubbing off the facetal articulation. Similarly, this is C1, this is C2, this is C1, this is C2. So you do rotatory imaging. So this is a new kind of thing that recently my article is published in Journal of Clinical Neurosciences. Please read it if you have time, or just listen to what I'm saying. There is Chiari and syrinx, no problem here. Rotatory, there is a dynamic rotation and unstable spine. So all these secondary issues like basilar invagination, instability is the cause. Compression and deformation is not the issue. Instability is the issue. And please have time to read this article that instability is the cause of basilar invagination and stabilization is the treatment. So for both group A and group B, There is only one treatment. Both are manifestations of chronic. Why sometimes group A, why sometimes this? You have to read these articles. And both these groups need C1, C2 fixation, basilar invagination, syringomyelia, Chiari formation, assimilation of atlas are all children of atlantoaxial instability and all need one treatment, and that is atlantoaxial stabilization. So this is syringomyelia, no problem here, little bit problem here, do C1, C2, see the absolute clinical magic. Radiological magic will always be there, but more important is clinical. You want to see your patient all right. And you have to only believe me that in the evening of operation, you will find a person who's a different, you can change his name because he's a different human being. Syringomyelia, Chiari, basilar invagination, no facetal malalignment, you do fixation and you see a beautiful. There is Chiari, syrinx, basilar invagination, no facetal malalignment. I am not doing any distraction. Believe me, another thing I'm saying, and be clear, I'm not doing distraction or decompression or any kind of secondary decompression or primary. Don't go under that nonsense kind of. I'm doing just unstable spine. I'm stabilizing. Syringomyelia reduced. This is another patient, and believe me, more than 600 patients. I can show slides after slides where the syringe has reduced. No problem here, no problem here. I have done distraction here. I've described distraction here, but I don't put articular spacers now in these cases. It is not necessary. So this is another case. There is no spacer here. Difficult operation, such rostral C1, C2 for Chiari malformation, but that is the trick. I am saying Chiari is secondary, Chiari is protective. All these things, basilar invagination is due to chronic neck pain and short neck. Torticollis is protective. Klippel file is protective. Assimilation of atlas is protective. C2-3 fusion is protective. And they are potentially or manifestly reversible. Syringomyelia is reversible in 100% of cases if you do scan after 6 months. This is in the 3rd or 4th day also it can reduce in a large number of cases. So this is syringomyelia, no problem here, little bit problem here. Do fixation and syringe reduce. Syringe reduction is not the issue. Patient improvement is, I've already told you, you will see a magic with the patient. No secondary or distraction is, no, I'm not increasing the posterior fossa volume at all. This is my concept. Posterior fossa volume reduction, that it is reduced is my concept, but I'm saying no concept. Unstable spine is the issue and stabilization, and the syringe will reduce. This is another syringe reduction, no problem here, no problem here, no problem here. See the beauty of the reduction. This is another case. This is when there is Klippel file anomaly. Now don't start decompression in Klippel file anomaly. Klippel file anomaly is one of the other children of chronic atlantoaxial instability. This is not a very remote cousin. It is a close brother of chronic atlantoaxial instability and Chiari and syringe. You do fixation. Syringe will reduce. Don't bother about syringe. Patient you bother and you will see magic. So there is syringomyelia reduction. No problem here. Fixation. These are not easy operations. Now people told me when I wrote this article, no, it will work only in basilar invagination, no complex Chiari, no, it will work in only this kind of situation and that. No, Chiari is second. I'm not talking of tumor and Chiari, cranial stenosis and Chiari, spina bifida. I'm not talking. I'm talking of even when there is no bone abnormality. So there is no bone abnormality, syrinx and Chiari. So what you will do here? So there is no bone abnormality, little bit facetal anomaly on lateral profile imaging. There is syringomyelia, you do fixation. There is no bone abnormality, little bit problem here on lateral profile imaging. Now, of course, you do dynamic rotation and see the magic. And possibly, if you have time to really read this article, please read it. So there is syringomyelia reduction. I'm not doing any distraction of facet. I'm not doing any kind of secondary decompression. I am doing just stabilization. Instability is the issue and stabilization is the treatment, and a beauty is the clinical outcome. So you see this syringe, no problem here, no problem here. The syringe reduces, and that is the issue. Syringomyelia reduction, no problem here, no. And if somebody argues, no, I don't know, this patient did not improve, that patient did not improve. If you don't know how to do C1, C2, only God can help you. This is a concept. I'm not trying to be too aggressive. I'm not trying to be too possessive, but this is the revolution and this is the future. When I'm saying I'm talking of 600 patients, you say, I don't believe. If you're not believing, come and spend some time with me. And if you don't want to spend time, then don't talk or read the article. Syringomalia, Chiari Malformations, Syringomalia, no problem here, little bit problem here. Do fixation and see the magic. There is syringomalia, no problem, reduction, C1, C2 fixation. So as I mentioned to you, there are several hundred patients lined up with me where all this syringomalia reduction, and one patient is lying with me in the ward today. He said, Doctor, I love you. Yesterday I operated and today morning, Doctor, I love you. That is the satisfaction, that is the gratification you can get. Syringe reduction. This is another 1 year after surgery, syringe finish. It will never finish actually. There is some kind of syringe and there is syringomalia. When there is failure, as I mentioned, I introduced the concept of tight posterior fossa. Many of my own patients have continued to have problems. What you do with, now my most common operation which I am doing nowadays is the failed, people have done foramen magnum and they are coming from all over the world. And this patient failed, somebody has done foramen magnum decompression, see the syringomalia. See, I'm showing you syringe cases more because it is more, visually seen. If I say there was no syringe and I did for Chiari, it is not so much visually seen unless you see the patient and give me about 5 to 6 hours of presentation. In 10 minutes, I have to show you the world of Chiari in a different perspective. So there is syringe, there is Chiari, there is foramen magnum. This patient underwent 13 operations. And a very high profile person, completely demolished by this concept of decompression, which I introduced in 1998. Understand, you see this rise to this catheter. This is immediately after third or fourth day, he's having straight neck, not so miserable, rise to gone, speech comes back. There is syringe, no problem here. No, because somebody has done foramen magnum decompression. He lost his voice. He got CSF leakage. Multiple operation, several days of ICU, and then this is a new life. When I wrote this article, someone, no, it will not work in pediatric age, it works in only adults. Completely not correct. Chiari in any case is relatively less common in children. These patients will have more sleep apneas. So there is Chiari and syringe, no problem here, no problem here. We do fixation, the syringe will reduce. As I mentioned, the syringe will reduce 100% of patients. Clipper file abnormality, see the syringe, see the bad kind of issue, and see the postoperative situation. So these are secondary. All these children are secondary to unstable atlantoaxial joint. Syringomalia is secondary. It is naturally protected. It can present, this one child can present alone without Chiari. Chiari can present alone without his sister syringomalia or without basilar invagination. But if whichever child is there, the problem is father. To treat the father syringe, nobody knows how to treat idiopathic syringe. Here is the answer for you. And here is the article for you to read. We have introduced a new concept of external syringomalia, another kind of a revolution in the field. You have to read this. There is syringe inside the cord, syringe outside the cord. This outside is external syringomalia. This has same implication as internal syringe, and it has got huge implications in understanding spine surgery. Kyphoscoliosis is another child, which is a little bit remote cousin living in another town. Kyphoscoliosis. Kyphoscoliosis may be secondary to central instability. It may be associated with his brothers like Chiari and syringe, or may be associated without Chiari and syringe. And when there is Chiari and syringe, so the whole family is here. The father, treat the father, and the scoliosis will be treated. Don't start putting rods after rods, and this result will be in the immediate post of this after 3 weeks of operation. See, the spine has become straight. You would have introduced several screws and several rods and demolish the person. Scoliosis and syringomalia is a subject. Rotatory dislocation can be a cause of kyphoscoliosis. It can be idiopathic dorsal scoliosis. Nobody knows what is the treatment. Eye movement disturbance can be present due to Chiari malformation. There is no problem here. Don't start decompressing. This needs stabilization. This kind of eye movements disturbance is quite a frequent issue in Chiari. The voice quality affection, sleep apnea. Sorry for this. And the other thing, beautiful thing I'm saying, you do fixation on the table, you can get 40 or 50% recovery in motor evoked potential. You cannot undermine these kind of observations. Either you don't, want to listen to this, or you don't want to just open your mind. This is Chiari and Syrinx. During operation, you see this motor evoked potential more than 40%. So you can create heroes, you can create smiles, you can create laughters, and you can be proud. And you can be and you can also get some beautiful kisses from all over the place. This is a revolution. Believe me, don't try to argue too much. Spend some time instead of argument on the papers, and you will find some beautiful answers. Foramen magnum decompression is historical. C1, C2 fixation will emerge as a more powerful tool in the treatment of various anomalies of the craniovertebral junction. Thank you very much.
Thank you, Abida, for sharing that. Unfortunately, as always, Atul has run out of time about by 15 minutes, but that's okay. We know him, so we'd spare him for that. Let's start discussion. So I'd start with requesting Mehmet to say a few words, and then we move on to our all the panelists.
Yeah. It seems that it is still a challenging disease, very unique portion of the human anatomy, and it is not just covering the brainstem and spinal cord, but also having big rotational movements. And we know that we are having good results with the decompression only. But Atul still insists to make fixations. Probably our speakers may make some comments on that issue, especially Jörg and Juan and Pravin. Pravin has already did his task. Yeah, this is what I want to say.
Okay. I've had a lot of discussions with Atul in the past on this topic, and I acknowledge his results as he presents them. On the other hand, I must say that I've been treating Chiari malformations for about 30 years now. And apart from patients where the Chiari was associated with basilar invagination, we did decompressions, opening the dura, opening the arachnoid, and performing a duroplasty. And doing so, we had immediate postoperative improvements in around 80% of the patients. And we followed up these patients for 10, 15, 20 years. And we found with Kaplan-Meier statistics that around 90% of the patients are more than satisfied with the surgical result for 20 years and more. So if decompression would be such a disaster for Chiari 1 patients, the results shouldn't have turned out like this. So there clearly is some disagreement at this point, in that decompression of Chiari 1 very well may serve the patient and may actually provide them a normal life, specifically if you do it in time in children and in young adults. And they have very, very nice results. On the other hand, we have to acknowledge that craniocervical joints have to be looked at very carefully, and that we have to analyze in each and every patient whether there's an abnormality there, and if there is, then fixation may be more than advisable and may actually be necessary. But it's not correct to say that, in my mind, that every Chiari patient has to be stabilized.
Don Jose, your turn, please.
Yeah, well, I agree with Dr. Klekam. There is no room for stabilization in all cases of Chiari malformation. In adult patients with classical Chiari 1 malformation, the decompression is enough to have a good outcome. I think, of course, in cases of basilar invagination with malformation, we can speak a lot about stabilization, but in classical patients with Chiari 1, no. I have patients operated since 20 years ago that are in good shape. Also, some of my patients are playing rugby, so probably there is no problem, no instability. I agree with Dr. Kleka, and I disagree with Dr. Goel.
Yeah, I think I must also share our experience in the last 25 years. And since Atul has been talking about it, we routinely now do looking for instability x-rays. And unfortunately, we haven't found many patients. I think in last 15 years, we have had only 3 patients in which we fused and we thought there was instability. The rest of them, for whatever reason, don't turn up on our door. So I'm not sure, but as far as we can see at the moment, consensus is still there that decompression is probably the way forward. Let's hear from Abida as she's here as well.
Yeah, Professor Salmani, I'll speak on behalf of Sir. So we have done a huge amount of cases now, and we are fixing. There have been series like maybe when I was a resident, we were doing foramen magnum decompressions. We are fixing those patients as well when they come back, and we are seeing the results. This remains a mystery. We are trying to analyze it in our own way as to why it is happening. But when we do open the joints, they are tremendously unstable. So that is definitely an indicator for us when we are operating that this is unstable. Like I've done a child about a week back, 2 years old, who was not walking, and I have fixed it without any kind of decompression. And within 10 days, the child has started walking. I mean, the patient was walking before, he developed some issues and then stopped walking, and now he started walking again. So the results, the clinical results are really dramatic. And as Sir says, you have to see it to believe it. And we'll come out with some reason of why it is happening for sure. But yes, instability is the cause for Chiari formation.
Sure. Oscar, would you like to share your wisdom as well? Can we? Okay, I've just unmuted you. Please unmute.
Sorry, guys. I was in a flight. I could not join earlier. I mean, I think when we talk about Chiari malformation, probably we are talking about different patients when we are talking about European patients or Brazilian patients or Indian patients. So, and grades of instability might be different on those patients. I really agree with Klekkamp. That's my experience with our Portuguese patients here. And we try to keep it as simple as possible, mainly sometimes doing most of the times just osteoligamental decompression, and it goes really well. Obviously, you have to go wide, so CSF can flow not only posteriorly but also laterally. I quite like the coronal MRIs to assess that. But I can admit that patients from India, from Brazil, there are elements of instability, and in this sense, it can make sense. It makes sense what Atul say. So I'm not sure we are talking about really the same patients. Thank you, Salman.
Thank you, Oscar. Praveen, would you like to add something?
Now, the patient population is same. We are in the same country, and in fact, I have tried fixing the C1, C2 in patients without any apparent instability, and the results are not all that promising, at least in my hands. So for some reason, just 70% of them improved, and it was almost similar to results of simple posterior fossa decompression. So for me, I would prefer to do a posterior fossa decompression first. This is not, I'm not talking about those patients with assimilated arch of atlas and some so-called basilar invagination or vertical invagination. I'm not talking about those patients. I'm talking about simple the Chiari malformation type 1 without any apparent instability and normal C1 arch, and then we just fix C1, C2. For me, that is an overkill. We can always do a posterior fossa decompression first. If the patients for some reason do not improve, then we can give a trial of C1, C2 fixation, but that comes later on. And probably as Professor Klickamp had shown some Chinese paper about the OC1 instability. I had actually reviewed that paper, and possibly it is like, there could be something else. And I personally feel that we are missing something. It definitely is not instability. It is just fixing C1, C2 in all cases, to me, appears to be an overkill. So I would prefer to do a posterior fossa decompression first, and later on, if there's no improvement, maybe give a trial of C1, C2 fixation. And if even that fails, I don't know what to do.
Okay, brilliant. Dr. Yunus Aydin has suggested that absence of gag reflex could have a role in indication of surgery. So, George, what do you think about that?
Well, if there's evidence of coral cranial nerve deficits, this usually indicates medullary compression of the brainstem. And in most instances, it's a compression from anterior. So if I see a patient with Chiari presenting with problems of swallowing, then my suspicion is that this patient has instability in the craniocervical junction, and I will check that very, very carefully. Similarly, I will react if somebody is presenting with problems of ocular movements, such as nystagmus with gaze. That's also an indicator that something may be wrong with craniocervical stability. So these are clinical signs pointing you towards looking at this area more closely and analyzing carefully the anatomy of the joints in this region.
Okay, good. There's another question is how much decompression is required? Like, is there any standard, and what is really the goal of decompression? Jan Jose, would you like to take that question, please? How much decompression is required? How much do you do?
The decompression should not be very big. A craniectomy of almost not more than 2 centimeters and a resection of the posterior arc of the atlas. And I always do duroplasty.
Oscar, what's your take on that? Sorry, please unmute.
As I said before, we tend to be a little bit more generous on bone work, and we go laterally almost to the condyles and in the arch of C1 as much as the vertebral artery sits. And we always try to have CSF flowing laterally, not only posterior. And that's the cases that have been reoperated. It was due to insufficient osteoligamentary decompression. And it's not only bone. You always see a lot of fibrosis, a lot of duplication of dura, of ligaments, and all these needs to be really, really thinned. Almost leave just the inner layer of the dura. And with the pulsatility of CSF, this will expand eventually.
Okay. One point that actually we don't have a pediatric neurosurgeon with us. So then probably the pediatric patients can be differently managed. Just bony decompression or dural ligament cutting will be enough in some patients, in the pediatric patients. Another thing is previously we were telling that complex Chiari cases should better have duroplasty, but however, simple Chiari patients may have more bony decompression or dural band resections. What do you think about this? I wanted to know the ideas of Dr. Claycomb as well.
Well, this is an ongoing discussion for quite a while, whether bony decompression is sufficient for Chiari 1. The problem is that, at least in adults, the dura will not expand if you just decompress by taking away some bone. So in adults, it's quite clearly that you should open the dura and do a duroplasty in order to get a proper decompression. In children, you may get away with bony decompression alone. However, you have to accept that the number of patients who will require a second operation because of insufficient decompression will be higher if you just do a bony decompression and if you do not do a duroplasty. So if you want to avoid any recurrence, any necessity to reoperate on these patients, then you should do a duroplasty in children as well. But that's my view and the view of quite a lot of colleagues I know. But I do know that pediatric neurosurgeons, to some degree, disagree with this point of view.
And what about arachnoid layer dissection? Would you dissect, or would you just do expansile duroplasty?
I personally open the arachnoid. I personally look into the fourth ventricle, whether it's obstructed or not. If it is obstructed, I open it. And the number of patients that have an obstruction of the foramen of Magendie is not so low. It's in the vicinity of 20 to 30% of all Chiari 1 patients. So it's not something that I would simply leave aside. So I personally do that. I have no morbidity associated with this arachnoid dissection, and the results have been very, very favorable, as I outlined already. And we also did a study on the histological findings. We gave the arachnoid we resected for pathological examination, and we found evidence of fibrosis and evidence of vascular proliferation in some of these specimens. And even the amount of arachnoid fibrosis did correlate with certain neurological symptoms the patients presented with, and with the likelihood of an associated syringomyelia. So there are indications, no proofs, but some indications that the arachnoid actually does play a role in the pathophysiology of these patients. And that's the reason why I do the arachnoid dissection in my patients.
Yeah, when we did the WFNS consensus meetings, we came up with this, that the overall consensus was that decompressing only without arachnoid dissection had same results as duroplasty, and also going into the arachnoid itself, except for when patients had arachnoid dissection, there were higher complications compared to the ones in which arachnoid dissection wasn't done. So that was the consensus statement, one of the consensus statements from the WFNS meetings. But surely there are different types of patients and different problems. So every patient should be taken as an individual. Any other comments, please? Mohammed, would you like to wrap it up, please?
I think we discussed it enough. Maybe I want to give a few words to Dr. Yunus Aydın, who is with us. He's a valuable faculty from Turkey. Would you like to say something, Dr. Aydın?
Sure. Thank you. Actually, my question is about the size of the decompression. Decompression size is very important. If you look at the preoperative MRI, check the subarachnoid space retrocerebellar area. That shows the size of the decompression. we need to decompress the posterior part of the cerebellum to open the CSF pathways. And also, I routinely do duroplasty. The CSF leak after surgery might be this first sign of the maybe improper closure of the dural. But the second and frequent one, the inefficient decompression and still going on some stress and increased CSF pressure and causes CSF leak. I do a lot of reoperation for inefficient decompression.
Thank you.
So, thank you.
Okay. It was a great talk. I thank all the speakers and all the moderators. And I think we will meet again on this Wednesday. Professor Al-Mefti will be the presenter, giving a conference to all of us. And I invite all the participants to our future meetings. I think we can finish it here.
Thank you, everybody.
Thank
Have a
you.
good day. Bye-bye.
Bye-bye.
Cheers. See you later.
Bye-bye.
Thank you very
Bye-bye.
much. Bye-bye.